morning after listening from our two neighboring country, one who is no cornea collection and who has surplus cornea. I think India is in between the transition stage. I think this symposium is really APAO because we have representative from many countries. So I'll part of this thing is covered by Sunita also because what will happen in 2030. So I'll just from EBI side will tell about the update of the collection and what is the goal. The goal is to improve definitely collection and utilization rate. Like Minu told, they have a utilization 80% in India is not the scenario. And quality control like accreditation, and I always dream of graft registry. And Nepal is already sending tissue across the border, whereas in India we don't have. So this statistics is few years back. I don't know whether it is correct or whether we is worsened or improved. Because if you ask many eye banks or many cornea surgeons, they say they don't have a waiting list. But I believe it is not uniform around. Maybe some people in the rural areas still waiting. So that time, as for the calculation, we require 2 lakh cornea to be harvested, thinking that 50% utilization. Even if we don't do 2 lakh, because if you see the graph, it is like a really a V shape. The highest is 27, like to 58,000. So compared to 2 lakh, even if we don't reach 2 lakh, I think if we improve the utilization rate uh, by doing 1 lakh 50,000, we may do 1 lakh collection. So to reach 1 lakh 50,000 also, we need to improve 3 times. So the calculation that time per 2 lakh is 4,000 cornea per year from one eye bank and 50 eye bank. So this is the current scenario of the eye bank number. At present we have 740, but if you see how many are collecting above 1,000 is 14 eye bank. So we need 4,000 cornea collection from 50, and above 4,000 is only one eye bank, and 14 eye bank is above 1,000. So the planning for collection by 2030, that we need more eye collection center rather than eye bank. Eye bank is a glamour, but to run the eye bank is not easy. So eye banking activity is mostly localized to few metros and few bigger institute. It should be in the different part of country. And training center, we need training center, at least pipe zonal training centers. And most of the, like Minu mentioned, and all of us know, HCRP gives us good quality of cornea and more utilization. Also, a lot of coordination and maybe government help is required to improve our HCRP collection. At the same time, spreading awareness in the community. This was long back in 2020, 2010. You can see different zone collection and utilization. So it's always South Zone who leads the show. So you have to focus on different zones to start iBanking activity. Coming to utilization, how to improve utilization rather than collection. So as I was mentioning, we may not collect 2 lakh, we may collect 1 lakh 20,000, but if we increase the utilization rate, we can reach the target. Focus on more lamellar surgery. As Dr. Parihar was mentioning, from the where the patient come, it is not, one is from where, and the most likely will not, lamellar surgery will not more than optical or penetrating in India even next 50 years, because infection is major component. And training of cornea surgeon, like, luckily now most of the cornea fellows who go to their place, they get cornea because of the corneal distribution system. Still we need lot of cornea surgeon, and well designed cornea distribution system, it is there but is not completely like working out. And more transplantation center, again we need help from government. And tissue transportation is big challenge, because many of the airlines, they don't carry the tissue. Even if they carry, they charge heavily, so it has become a difficult. And quality control accreditation, again Nepal Eye Bank was accredited by EBI, but however it was with Site Life, sometime it was with, but NABH has not taken into account for the or any organization. So maybe EBI will do the accreditation and give the eye bank. For that we need to train lot of assessor, and who will accredit either EBI or in addition to EBI, NPCB or NABH. So graft registry is available in many countries to know the long-term outcome of many grafts. So in India, we don't have. Otherwise, some institute have their own, but if you see the throughout the country, we need a graft registry. For that, we need a strong database. Again, the manpower should be trained. And more main challenge, I've spoken to Dr. Basak also. He says always you start and let us see the proper documentation by cornea surgeon. We struggle for the recipient form, so it will be a big challenge. The cornea surgeon should be documented as for the format if you want to do this. And this is a big question mark, but I assume in 2030 India will have sufficient tissue to send across the border, at least to start with therapeutic tissue, because many countries in Africa they don't have even tissue to do for emergency purpose. The bottom line is, even if it is a therapeutic tissue and people are waiting, no tissue should go waste due to lack of recipient. We say that we have a lot of waiting list. We did this survey during COVID, and you can see this focus this graph. You see that 1.6% has only 90 to 180 days. So almost 98% surgeon they have a waiting list less 90 days. So I don't see many waiting lists in major places. So for that to convince government, we need legislation. We need to have epidemiological data about the demand supply gap, because the calculation extrapolation was long back, maybe 20 25 years back, and we need to change in legislation. So this already Sunita has mentioned. We should focus on utilization and usage of intermediate cornea storage solution. I know many eye bank they have moved completely to intermediate storage solution rather than short-term storage solution. And like processing fee, in many forum people ask what is the why is the processing fee, but we have to change from charity model to self-sustainable model. It may not be profit making. And in future, EBI may be eye and tissue bank. So this first part is already many eye banks have started sending. And DMEC roll from Ramayama Eye Bank, we send to DMEC roll to everybody outside this. And eye and tissue bank in future, we must be doing eye and tissue bank. So way forward, we should start in all states, and iBank training center in different zone for eye donation counselor and iBank technician. I feel this should be combined donation counselor and technician. This should be multi-purpose. And this I always feel many graft we lose because the ophthalmologist they don't know how to manage corneal transplant. So general ophthalmologist should be trained and more trained corneal surgeon. And more lamellar surgery, we can have a survey, epidemiological information about corneal blindness in different part of the country, corneal registries, mandatory accreditation, all these maybe by 2030. So we have 5 years in our hand, involvement in advocacy and policy making. Thank you.
Thank you, Sujata, for this overview of current status of iBanking. But a few comments like for Government of India, blindness is not a problem in our country at present. Because we have worked together as a AIOS president, I was working for last 1 year, I really thought why. So NPCB is not there now. NPCB is shifted to NCD, non-communicable disease. iBanking was a major part of NPCB work, we knew that already. So from our broad perspective, the cataract, last year we have done 9 million cataract surgery. So blindness coverage is done. So right now the prevalence of blindness in India is 0.25. Whereas it was 1, then target was 0.35, then it is 0.25, target reached. So they will not churn up the NPCB again. So iBanking, whosoever doing, it is our own. Government support probably will not be there because last few years we are not getting government support. This is from what is my understanding with the talking with the government official. Second thing is that data gap, there is a huge data gap in all sector. But consider what you are telling, that is correct. The waiting list of majority of the eye banks who are doing in huge volume of keratoplasties, We know there are least number of waiting lists, zero waiting list. You always say that I have almost zero waiting list, right? Your place, our place may be 20, 30. Aravind, those are big, big institutions. They are doing more than 1,000 keratoplasty every year. But if you really say that, what is the actual number of corneal, I mean, I call it transplantable corneal blindness, not corneal blindness. So if you consider the transplantable corneal blindness, and if you take the last RAB data of 15-19, they say the corneal blindness is the second largest cause of common blindness after cataract. If you put that data in our 1.42 billion of population, then you take the percentage, you take the prevalence, and it comes to 4,20,000. I have written that in my guest editorial. 4,02,000 is the number. So if you take the transplantable corneal blindness among these 4,02,000, so maybe 10%, 15% from our regular, you cannot take all the corneal blindness into transplant. We see what is prognostically much better, so that no tissue should go waste. Therapeutic keratoplasty is one thing, but for optical reason, we do not like, you also do not like, many people do not like. Why? You are doing more problem to the patient, for his or her quality of life will go after transplantation. So it is better not to. Likewise, we do not do one-eyed mostly, where the prognosis is very poor. So these are gap. Regarding third comment is regarding NABH accreditation. Recently we have the full accreditation has been done in our main hospital. And they have checked our iBank also. In-house iBank, it is included in their thing. And that is also, they have seen each and every corner. They have spent almost 3 hours rather than spending more time in OR or other things. And they see all the records, whatever the points. We have shown that these are the 16, 17 forms and other things, and all database, all computerized, EMR, whatever is there. And it is included in our NABH accreditation system. So my understanding, again, there is no clear-cut guideline, but if you have your own iBank in your own institute, like Ramayama International iBank within the institute, and there are many like RP Center and others. So if NABH accredited the whole system, iBank automatically will be included into it. So you will be, and last time when they visited, they raised 4 or 5 questions, we have corrected it, I can see corrected. And so
No, NABH in Bhubaneswar also, they come to iBank, but they spend hardly 15-20. They raise NC.
Sir,
Maybe somebody who is an iBank person who was the assessor.
no, maybe, but still, feel legally, medico-legally, we are in a better place now.
They come to iBank, but they
But standalone iBank, I do not know how it is possible.
sir, even but in the as a total NABH in a fifth NABH standard also, but the iBank is not included in their objective elements. We may have in our scope
But
of
whatever
service.
total
In a scope of service, you can add it, but when they give certification, they don't write ophthalmology, iBank separately.
they don't write. They give whole the structure.
Yeah, it's an eye hospital.
Right. So, okay.
Swati wanted to
So-
say something. Swati?
No, standalone iBank, that is a real problem, and